Thank you so much for having us. I think we're really excited to go over this topic because we understand how scary it can be to open up a report in your chart or get a phone call that shows some unexpected or unfortunate news. So we're going to talk a little bit about the information that you get on those reports, the types of different reports, kind of how to unpack them, and go into a little bit more detail, and then hopefully answer lots of questions. So the first thing we're going to talk about is a biopsy report. And a biopsy is generally your first step in a diagnosis. And sometimes this can be done by a radiologist if you've had a finding on your mammogram or an ultrasound or an MRI or even a palpable lump that you feel in your breast. This can sometimes be done by a doctor in the office if you have a mass that you can feel. And the goal of the biopsy is to sample tissue from that area just to get a diagnosis, not necessarily to remove the entire thing, but to get the information we need to plan what happens next. So here we have a sample report from a biopsy itself. And you can see there's lots of information here, but in general, what it talks about is where the biopsy was taken from. So it says which side, and it usually says the location within the breast. So I always tell people that we talk about the breast kind of like the face of a clock. So 12 o'clock is straight up and 6 o'clock is straight down, and everything else kind of falls into place. And that's so we all know when we're reading it where the area is of concern. And then it gets into what they found. So if there are cancer cells there, what type of cancer cells, the grade, a little bit more information. So to unpack a little bit about that, let's talk about the initial findings. So whether or not there are cancer cells there. Cancer cells, there's a lot of different types of cancer cells. So breast cancer is like an umbrella diagnosis with lots of kind of different subtypes underneath it. So we often see in the kind of pre-invasive or in situ disease, that's called ductal carcinoma in situ, or DCIS. And that's what we call stage 0 breast cancer, very early. And then we move into the more invasive breast cancers, of which we see usually things like a ductal cancer or a lobular cancer. There are other less common subtypes within those kind of areas, but those are the most common. And I always say that someone had the brilliant idea to put the word invasive in front of a cancer diagnosis to make it sound even scarier than it is to begin with. But what invasive means is that the cancers have the potential or the abilities to spread to other places. Whereas in situ is that early kind of stage 0 doesn't yet have the ability to spread. The next line that you see is the size of the tumor in the biopsy. And it's important to know that that's not necessarily the size of the tumor or the cancer that we see on your picture. It's just how much they saw in the little piece they removed with the biopsy. So it doesn't necessarily give us a great idea of the true size of the actual tumor. It's the imaging that does that at the outset. And then the next thing you see is the grade of the cancer. And grade goes from low to intermediate to high, or 1, 2, and 3. Grade is kind of like a measure of how organized the cancer cells are, and as they become more disorganized or more poorly differentiated, they start to get a little bit further away from normal and potentially a little bit more aggressive. The other thing to know about all this information is these are kind of like pieces of the puzzle that we put together to give us a big picture idea of what your tumor looks like, how it might behave, and how we want to treat it. So one thing of this in and of itself is not necessarily the be-all end-all of your cancer diagnosis or your treatment, more like these are all pieces of the puzzle. And then Dr. Yellala is going to talk a little bit more about the different things that we test on the tumor that help guide treatment.
So thank you for that, that's excellent. So in order to know what a particular subtype of breast cancer is in anyone who's diagnosed with breast cancer, we look for 3 markers which are at most important. One of them is estrogen receptor, the second one is progesterone receptor. Both of them are considered hormone receptors. One can be positive, both can be positive, or both can be negative in general. And the third marker we look for is what is known as HER2. So these are the 3 markers we look for in each patient on the biopsy to kind of know how I need to treat a particular subtype of breast cancer. So based on these markers, breast cancers are in general divided into hormone receptor positive HER2 negative disease, or HER2 positive disease, or triple negative disease. How they help us is it tells us about the prognosis, it tells us how aggressive your cancer can be, it tells us whether we need to do surgery upfront or chemotherapy upfront. So a lot of how we treat a particular cancer depends on these 3 markers. In general, the entirety of your tumor is generally have the same marker positivity. But however, there can be marker difference and heterogeneity within the tumor. We do repeat these markers at the time of your surgery in certain cases, especially the HER2. If your grade of the tumor is intermediate or high, then we repeat these markers on your surgical pathology report to be sure. And most of your treatment, I would say almost all of your systemic treatment that I give as a medical oncologist hangs on a lot on these 3 receptor levels.
Absolutely. And the important thing about biopsies is they do give us all of this information, and that helps us decide with surgeons like me, medical oncologists like Dr. Yellala, radiation doctors, whether or not we do chemotherapy or infusion treatments, anti-HER2 treatments up front, whether we do surgery first, what that plan looks like, all of that is kind of informed from the biopsy. So it's a lot of information, and it's really important. The other thing that you'll see on the very bottom line of that slide is something called a Ki-67 index. And people always ask me what that is and what's a good number and what's a bad number. It's basically like a proliferative index. It goes from 0 to 100%. And it gives us an idea of how fast the tumor cells are kind of growing and doubling and replicating, because that's what tumor cells do. They grow out of control. So a lower number suggests potentially a slower proliferation rate, and then a higher number suggests a higher proliferation rate. There's a lot of other information on this slide, on this biopsy report, that can be overwhelming. But I think at the end of the day, the big things are what type of cancer is it, what grade is it, and what do those hormone receptors and HER2 look like. And those are really the most important things to help us make a good recommendation for treatment plans. So the next type of report that you'll see is what we call a surgical pathology report. So if the biopsy is kind of what makes your diagnosis and kicks off our treatment planning and our recommendations, the surgical pathology report is the information we get back after you have your procedure to remove areas from the breast, be it a lumpectomy, a mastectomy, as well as from the lymph nodes, be it sentinel lymph node, complete lymph node removal. All of those things will be reported out in the surgery report. If you elect to have double mastectomy surgery, they will also look at the opposite or the non-cancerous breast as well, and they'll double check everything. So it's pretty standard practice during a surgical pathology report for them to report on everything that was removed during your surgery. And so for that reason, these reports are a lot longer. They contain a lot more information. And so we're going to go through again what those kind of highlights are on that report and what to look at there. This is kind of what we call the final word, because this is where they get a lot more tissue. The biopsy is a small sample of the tumor, a small amount of tissue. The surgical pathology is the whole thing removed. And so this is kind of what we use to make decisions on margins, on if you need more surgery, if more lymph nodes need to be removed, all of those different things. This also helps us confirm the stage of your cancer, and we'll talk about that a little bit more after we go through the surgical pathology report, so you can have an idea what how we stage breast cancers, because again, that's another really common question is, well, what stage am I? So let's look at the biopsy or the surgical pathology report. Again, there's a lot of information here. The key points usually are on the first page of the report. And then there's a second page usually with a lot more detail. And then there's a final page that really is just a description of how the pathology team prepares that tissue for them to analyze. So I wouldn't get too bogged down in the last few pages of that report, because a lot of that is just technical stuff about how they're actually preparing the tissue and doesn't actually have anything to do with your diagnosis or your actual results. So the first page that you'll see here looks a lot like the initial biopsy report. So you'll see that it says the side that we do the surgery on. It tells you the type of tumor, and it'll tell you the overall size of the tumor. And this is really the overall size of the tumor itself, right? Not just a piece of it, but the whole thing. So this is a bit more accurate in terms of estimating the true tumor size. You'll see the grade. That'll be repeated again on the surgical pathology report. And then it'll tell you about the margins. And margins are whether or not we got the tumor out with a rim of normal tissue around it. And we want margins to be clear. We don't want there to be tumor touching those margins, because if the tumor is touching the margins, then we always worry that potentially there could still be more tumor left inside you. And in that scenario, we usually talk about going back to do more surgery to remove more tissue. If you have lymph nodes removed, you'll see that underneath there. So in this report specifically, there was a sentinel lymph node, which means we're sampling the first few lymph nodes that along the chain of the lymph nodes that drain the breast. And so depending on the number of lymph nodes you take out, you may see a couple different entries in that area. And sometimes your surgeon will take out a little bit of extra tissue from the breast during your surgery. If it looks a little bit close, if they're not sure if the edges are going to be clear, sometimes we take out a little bit extra tissue right then and there, and that will be on your report as well. So the kind of highlights are on that first page, and you'll see, as Dr. Yellala mentioned, the estrogen and progesterone receptors, and HER2, if it's repeated, will be on that first page as well. When we get into the details that are on that page, things like the biopsy site, whether there's a clip there, all those things, those are just looking at the tissue that we removed to confirm that the area that they sampled during the biopsy is in what we took out during the surgery, which is obviously important because we want to make sure we took out the right spot. And then if we go to the second page of the report, which is often called synoptic data, this is a little bit more information, and Dr. Yellala can go over that a little bit in terms of what all of that really means.
So they look more into details of the tumor size, again, like we talked about in your biopsy report and on the first page. And they'll tell you how many tumor foci there are. Is it a single tumor, or are there multiple small little tumors inside the whole of the removed tissue in your breast? It talks about the grade again. Grade generally, there is nuclear score, mitotic score, architectural score. That is how we come up with numbers 1, 2, and 3 to give a final grade to your tumor. A lot of patients usually get confused between grade and stage. They might be stage 1, but they'll be grade 2. So they'll ask, someone told me I have a stage 1 tumor, but this says grade 2. So grade and stage are not the same. Grade is something we look, again, it's how well your cancer is differentiated. And what that means is how similar it is to your normal breast tissue. The more dissimilar it is to your normal breast tissue, it is a higher grade. That means your tumor cells don't look like normal tissue. They are kind of making more changes within the cells, so they look very abnormal. So higher grade tumor, again, doesn't necessarily play into our treatment decisions as such, but it can be important in certain, situations. Stage is completely different. We can talk about it going forward. Stage is when, breast cancer is generally divided into stage 1, 2, 3, and 4, depending upon the size of the tumor, the lymph node, and the distant spread. So grade and stage are two different things. In addition, because you're not only removing one specific spot of the tumor, you're removing the whole of the tumor and some normal tissue surrounding the tumor, you can see something called as in situ carcinoma. In situ carcinoma, like Dr. Maxwell said, it's not a true invasive cancer, but it can be a precancerous lesion or something that, if left behind, could have converted into a more aggressive invasive cancer in the future. So sometimes the synoptic data says there is DCIS or ductal carcinoma in situ, or LCIS, which is lobular carcinoma in situ. And people often ask me, what does this mean? Does this mean I have additional possibility that there is more DCIS left inside my breast, etc.? But again, margins are what becomes important here. As long as we have clear margins, meaning there is some amount of normal tissue surrounding the tumor, we do not have to go back in to do additional surgery. And like we looked at the first page, there are sentinel lymph nodes. So this data gives more information about how many lymph nodes are removed, how many are examined. And when you say treatment effect in the bottom part of the slide, what that means is not everyone gets treated before surgery. So, most of HER2 positive disease as well as triple negative disease get some form of treatment before surgery, which might include chemotherapy as well as immunotherapy as well as anti-HER2 therapy depending upon the type of the tumor. So if you have received some kind of treatment before surgery, the goal is to kill the cancer cells, right? So some of the cancer cells might be dead and they look different on the tissue. So treatment related changes can look different under a microscope, and that is what they report it as. And coming to the very bottom, it says staging. And like I said, that depends on the size of your tumor as well as your lymph node status. Generally, if a tumor is less than 2 centimeter and lymph node negative, it's a stage 1 tumor. If it's greater than 2 centimeter or lymph node positive, again, this is just a very, I'm just giving you a very broad idea of what it is. There are specific minute details to go into, but it also gives information about what your pathologic staging of tumor is. That's what PT1C means. And there can be some more information on there which might give information about lymphovascular invasion as well as perineural invasion, meaning your breast tissue does have lymph channels running inside it, and it also has nerve channels and nerve sheaths surrounding it and in it. So if a breast cancer spreads into one of the lymph channels, they report it as there is potential possible invasion into the lymphovascular spaces. And that's what perineural invasion also means. Again, doesn't necessarily entirely dictate how we treat it, but tumors that have perivascular, lymphovascular invasion or perineural invasion are generally higher grade tumors, and they might be at a slightly higher risk of coming back. So we do anything and everything after your surgery to reduce that risk of this cancer coming back.
I think that one of the things that's really important to realize about these biopsy reports is that the pathology team are the doctors that look at the tissue under the microscope, and they're basically just calling it as they see it, right? So anything that they see in that, they're going to put in this report, which is good because we want to know all the details, but which is hard because it's sometimes hard to shift through these and decide what really makes a difference in how we treat you. What does this really mean? Does this really have a big effect on your overall prognosis? Because at the end of the day, it's all about the big picture, right? What treatment do you need and how is it going to turn out for you at the end? And so it's hard to not get bogged down in these details because it's you and it's your body and it's your tissue and you want to know what every single word means. And I always say that that's what we're here for, is to go through these reports with you line by line to make sure you understand what they mean and make sure you understand what it means in the big picture, because really I think that's the most important. So the next page of the biopsy report that we have here is just a continuation of that additional data that talks about the lymph nodes. And they'll talk about whether or not we think there was distant disease, which can be determined sometimes by imaging that we do prior to your treatments, by your symptoms, any of those types of things. And then as Dr. Yellala mentioned, they will report back out on the estrogen, the progesterone, and the HER2, as well as the Ki-67 that we saw in your initial biopsy. So really a lot of this is redoing the tests that were already done on your biopsy to confirm that now that we have more tissue to look at, because remember the surgical report is on everything that we take out during your surgery rather than just a little piece of it, they repeat these tests to make sure that the tests they did initially on that smaller biopsy piece of tissue were accurate and correct. And at the end of the day, the final surgical pathology report is really what we use to help dictate that information. And then the final slide we have before we kind of talk about staging, this is the part that I've said you don't really need to worry about. The part that says source or gross is really just about how they prepare the tissue to be analyzed under the microscope by the pathologist. So it has nothing to do with you or your tumor or your treatment or your prognosis or anything like that. They do put it in the report, and so sometimes people come in and, they've highlighted specific words and say, what does this mean, or what does total formalin fixation time mean? At the end of the day, I mean, we can tell you what it means, it's just how they prep the tissue, but really doesn't change your treatment. So try not to get too bogged down in that one. The highlights, the most important stuff, are usually on the first page of the report. So the final thing that we're going to talk about is how do you stage a breast cancer, because that's a really important part about this. And I mean, I think the short answer is it's complicated, but in general, when we stage a breast cancer, we use the input from the overall size of the tumor, whether or not lymph nodes are involved, and whether or not we think you have distant spread or metastatic disease. And the combination of that information is how we put together the overall stage. Sometimes the estrogen receptors, the progesterone receptors, and the HER2 status can factor into the stage as well. So if you have a more aggressive tumor, like a triple negative or a HER2 positive tumor, that might slightly bump up your stage beyond what the kind of tumor size, lymph nodes, etc. are. So I think if you have questions about the stage in particular, that one can be a little bit more hard to kind of pull out of your hat and say, oh, it's easy, it's a stage 2, or it's a this, because even within the stages, there's a 2A, there's a 2B, and so, things get divided up. So I think that's a really good question for your treatment team if you want to know your particular and your exact stage, which is, of course, a very reasonable question to ask and a good question to ask, but there's a lot of pieces of information that go into it. So that's kind of where we get our overall stage. And we stage things at diagnosis, which means based on your pictures, which is the clinical stage, because that's based on the mammogram, the ultrasound, the size of the tumor on those, as well as your biopsy. And then you have a pathologic stage, which is based on the final report from your surgery. So, like I said, stage can be a little bit hard to understand, and it happens at different points in your treatment. But your final stage is generally what we call the pathologic or the prognostic stage to take into consideration the estrogen, progesterone, HER2. So I think from our perspective, that's really the deep dive into what your biopsy report and what your surgical pathology report means and how we kind of help define your diagnosis. But we are going to take some questions now, I think, from the live, if there are any. Is higher grade more severe? So higher grade means that the tumor has a potential to be more aggressive because the cells have already moved further away from what your normal cells look like. The grade in and of itself, I don't know if you would agree, but I usually tell people it's not the be-all, end-all. But in the bigger picture, it suggests that the tumor has the potential to be more aggressive. And we often see a higher grade in tumors that we know are more aggressive, like Dr. Yellala said.
Triple negative tumors or HER2 positive tumors that have also a high proliferative index. Your Ki-67 number will also be high. But will a grade 3 tumor by itself dictate my treatment? No. Again, it's just means that it can be a little more aggressive kind of tumor, but it will not change anything in terms of how I treat you.
Kind of like one of the pieces of the puzzle. Yeah. And how many grades are there? So grades go from 1 to 3. 3 is the highest, 1 is the lowest, and 2 is right in the middle, intermediate grade. Can the grades change? Sometimes, if you have a tumor that's a little bit larger, as Dr. Yellala mentioned early, sometimes you can have areas of the tumor that behave slightly differently or have slightly different profiles than another area. If the tumor is really small, like less than a centimeter, I think that's probably less likely because there's not that much tumor to kind of have that differentiation within. But if you have a larger tumor, sometimes we see parts of the area that are a grade 2, parts are that a grade 1, etc.
And generally when they report it out in the surgical pathology report, they report out the highest grade that they see in that particular tumor. Let's say one area of your surgical tumor, the tumor removed during surgery is a grade 1, the other area is a higher grade, they generally report the higher grade. in your final report.
Because in general, we treat to kind of the higher level.
Yeah.
So we want to make sure we're not under-treating and putting you at higher risk for something coming back or causing a problem. So, you know, we tend to report out and treat to the higher level when there's differentiation between things. Does DCIS mean that a person doesn't have cancer, yes, or did we just catch it early?
So, very good question. A lot of my patients ask this. Okay. So some people have DCIS throughout their life without it ever becoming cancer. And we just never know, right? Some people don't even get mammograms, so there is no way of knowing it. But if we find a DCIS on your biopsy, we will suggest taking it out. 2 reasons. Number 1, biopsy is just a representative sample. It's not the whole, like, it's not a representation of what is going on in there. It's just one specific site that is removed, right, through a biopsy. So we suggest doing surgery on a DCIS, suspected DCIS tumor, to make sure there is no invasive cancer hiding in there. The second reason is DCIS can have a risk of getting converted into an invasive cancer in the future. The risk is about 1 to 2% per year of the recurrence too, actually, but that is why we remove DCIS. It used to be called stage 0 breast cancer, and we sometimes use that even today, but it is not a true invasive breast cancer. It's a precancerous lesion which can be treated by surgery and endocrine therapy adjuvantly.
And that doesn't mean that a diagnosis of DCIS isn't considered kind of under the bubble of breast cancer. I think everyone who treats breast cancer probably says, yes, it's kind of a precancerous lesion, but sometimes you can have a really large area of DCIS. So even though it's all stage 0, if you want to call it that, or pre-invasive, precancerous, sometimes people need big surgeries like a mastectomy to make sure we get it all out. Sometimes people need radiation after a lumpectomy treatment. So we still treat it pretty aggressively. The big difference, I would say, is that because it's that precancerous lesion or pre-invasive lesion, it doesn't have the ability to spread to lymph nodes. So chemo, Dr. Yellala's area of expertise, is usually not recommended or really never recommended in that scenario. But it doesn't mean that we don't treat it aggressively, or that you might, you know, you may still have to undergo things like surgery and radiation, things that still are stressful and disrupt your life and your day-to-day and all those things. So I think that if you have a diagnosis of DCIS, you can absolutely kind of consider yourself a thriver and a survivor and all those things, because it's still a challenging thing to go through no matter what, for sure. So if someone was pregnant when their tumor was found and they were estrogen receptor positive, so their tumor was hormone sensitive, would getting pregnant again cause the tumor to come back?
Not necessarily, not all the time. Yes, when you're pregnant, you know, there is all kind of hormone imbalances in your body, especially the level of progesterone goes very high, and that can stimulate, you know, a breast cancer cell to grow, but it necessarily doesn't happen again just because you have had one episode of this. We still are learning a lot about why breast cancers happen in some pregnant women, doesn't happen in some pregnant women. So there is a lot of genetic, environmental factors that go into it. So no, necessarily it will not happen. It might not happen again just because you have had one episode of it while you were pregnant.
And we don't tell people that they can't get pregnant again after a cancer diagnosis that's estrogen sensitive. Sometimes the treatments that we give can interfere with that, and that's something that's really important to talk about at your diagnosis, about your future fertility if that's something you desire. But at the end of the day, if you have an estrogen sensitive cancer, whether you're diagnosed when you were pregnant or you weren't pregnant, and you desire future pregnancies, future fertility, that's not a hard stop to say that you can't try to have a baby again in the future. It just is a conversation because, you know, there's a lot of stuff that goes into all of those things, and we want to make sure that whatever we do for your cancer treatment, we preserve your ability as much as possible to get pregnant again in the future. But certainly it doesn't mean that you couldn't have another baby, or you shouldn't have another baby in the future, and your cancer would not necessarily definitively come back if you were pregnant again. Are larger margins better or any margins okay? Oh, this is every surgeon's favorite question. So there are kind of rules, I guess, if you will, about margins that are based on decades and decades of research about what's the safe margin to take to reduce the risk of the cancer coming back as much as possible. And right now for invasive cancers, so anything that's a stage 1 or above, so not DCIS, we just want a clear margin. So the margin can be a millimeter, it can be a centimeter, it can be 10 centimeters, and we don't think that that necessarily changes your risk of recurrence. All we want to do is get it out with a clear margin around it. Counterintuitively, and I know that this sounds crazy, DCIS, or that precancerous stuff, we actually want a slightly bigger margin on that one. We want to get at least a 2 millimeter margin on that, which sounds crazy because everyone says, well, if it's precancerous, how come you got to take out a more clear margin and more tissue? And that's because for DCIS, sometimes you can have what's called a skip lesion. So sometimes you have a little area of DCIS and then a little area of normal tissue and another little area of DCIS. And so we want to get a slightly wider, not miles or anything, but a slightly wider margin on the DCIS, which sometimes is a tough one to wrap your head around. And I know when I talk about it with our students, they always say, this makes no sense. Why do you need to take more tissue out for less aggressive disease? But in general, a clear margin for invasive disease is all you need. A larger margin is not necessarily better. So as long as you can clear the margin, you don't have to worry about doing more surgery in that scenario. When do you recommend doing a lumpectomy over a mastectomy? Oh, this really is my favorite question, actually, I think. So in general, we know that a lumpectomy surgery is often followed by radiation treatment. And the combination of those two treatments, the lumpectomy with radiation afterwards, is really, really effective. And in people who don't have a really strong family history or people who don't carry a gene mutation like a BRCA mutation or any of those ones that we test for, in general, lumpectomy with radiation treatment is as effective, if not a little bit more effective than a bigger surgery like a mastectomy in preventing the tumor from coming back. A mastectomy is certainly a good idea if a tumor is really large and we don't think we can get it all out with a lumpectomy, especially because the goal of a lumpectomy is to take the cancer out and leave you with a breast that still looks like a breast that you can be happy with at the end of the day. So if there's a danger that we can't get the tumor all out, then certainly a mastectomy is recommended. If we know that you carry a gene like a BRCA1 or 2 gene or other genes that are related to future risk of breast cancer, sometimes a mastectomy makes more sense because we're both treating the tumor you have and reducing your higher risk of future breast cancers. Sometimes people have reasons why they can't get radiation, and sometimes in that scenario we recommend a bigger surgery because the mastectomy can be more helpful without the radiation. And then, of course, there's always, a discussion with the patient and their preferences, and it's ultimately a very open discussion to have. My personal thought is that if we can get your surgery out with a smaller, we can get your cancer out with a smaller surgery, and you can get the radiation and you can get as good a result, then a smaller surgery is maybe a better idea. Bigger is not always better in surgery, but that's such an individual decision. It's hard to say kind of blanket statement, oh, you should always have this or you should always have that. What level of diagnosis leads to other treatments? So I think that...
The question, I don't necessarily understand the question.
Sure. You go ahead.
What does the question...
So what level of diagnosis leads to other treatments? So most breast cancer diagnosis, be it DCIS, stage 1, stage 2, etc., most each levels, I would say, of diagnosis, most people have more than one type of treatment. Because, for example, surgery alone, I can get rid of the tumor with a surgery, but I can't necessarily prevent it from coming back. And that's where Dr. Yellala comes in. Yeah.
Sorry about the confusion there for a minute, but yes. So breast cancer, we always say, is a combination of surgery, radiation, and systemic treatments. And the systemic treatments that I give may include chemotherapy, may include endocrine therapy, or may include both of them. So it depends on what subtype of breast cancer you have. You might need all three together sequentially, one before the another. So radiation almost always comes after surgery. However, systemic treatments like chemotherapy and anti-HER2 treatments can come before or after surgery, depending upon how big the tumor size is, how many levels of lymph nodes are involved, what your marker positivity says in terms of estrogen, progesterone, and HER2 receptors. Again, you might need all three, which is surgery, chemo, and radiation, or you might need one or two of these three,
I would say that the level or your stage of diagnosis doesn't necessarily dictate the number of treatments you need, more as the biology of your disease. Right. Do you think that's fair to say?
Yeah.
So your estrogen, your progesterone, your HER2. But I think that most people who have a breast cancer diagnosis, regardless of stage or level, get more than one type of treatment. Getting more questions coming in the back. Can you describe what chemo is doing in my body? That's all, Dr. Yellala.
Sure. So chemo, the idea of chemo is it's a scary thing to hear. It's a scary thing to go through. Although I sit in this end of the side and say, chemo is recommended for this type, it can be scary, a lot scary for patients who receive the diagnosis and then know that they have to receive chemo. How chemo acts is that it is a cytotoxic agent, meaning chemo kind of affects the rapidly dividing cells in your body, and a tumor cell is always rapidly dividing cell in your body. So the idea is that chemo gets concentrated in your cells, the tumor cells, kind of slowly kills the cells from the inside. So it starves them of the necessary growth factors that the cancer cells thrive on, so that your cancer cells are killed. In the process, however, chemo does affect some rapidly dividing normal cells in your body. And when I say that, that is where the side effects come from. Chemo is not Tylenol or Advil, and you can't just take it and not expect to have any side effects. About 60 to 75% of patients who receive chemotherapy do have side effects, and that is because of the effects of chemo on your regular body cells, that are healthy. The rapidly dividing cells in your body generally are the cells in the gut. So that is the most common side effect people have, either related to upper gut, which is nausea, vomiting, heartburn, or related to lower gut, which includes diarrhea. In addition, chemo does affect, hair follicles, nail growth, and that is why people lose hair during chemotherapy. So again, all of these changes are temporary, meaning once we are done with the chemotherapy, the hair cells grow back. Your gut cells, again, they're rapidly dividing cells. There are plenty of gut cells being produced in your body on a daily basis. So all of those cells will regenerate. So yes, in addition to killing the cancer cells directly, chemo does affect your normal healthy body cells, which causes side effects. How is it determined how many chemo treatments I receive? Good question. Again, it all depends a lot on the biology of your tumor. And when I say biology, that again goes back to the three essential markers we look for, which is estrogen receptor, progesterone receptor, HER2 receptor. So the treatment for HER2 positive breast cancer varies. The treatment for triple negative breast cancer varies in terms of how long, how intense, what are the regimens. Even in the specific subtypes, let's take HER2 positive breast cancer. Most of these patients receive some form of chemotherapy before surgery. That may include about 6 chemo treatments for about 5 months in total. And they might most of them need to receive more treatments after surgery. However, that doesn't necessarily include chemotherapy as such. There are anti-HER2 drugs and antibody drugs that we combine. It's very hard to answer that question because it's a blanket question, and it really depends on what stage of cancer you have and what subtype of breast cancer you have. On an average, a patient with triple negative breast cancer gets treated with chemotherapy before and some form of infusion treatments after surgery for a total length of 1 year in both triple negative and HER2 positive disease. So yes, it's a long-term process, but it also depends on your response at the time of surgery to neoadjuvant chemotherapy, which is the chemo I give you before surgery.
And it's not every day or every week.
Yeah.
A lot of these are divided up over time. So it sounds like a long time, but you do get kind of a buffer zone in between. Yeah.
So the most intense chemo treatment that I give is once every 2 weeks, meaning you come to us, it's all done in an outpatient setting. Our goal is to avoid you being admitted to the hospital. Any kind of side effects, we try to manage them with medications at home. Again, the most intense treatment that I give is once every 2 weeks, meaning you get the chemo drugs one day, you come back 14 days later to get the second cycle. So, and yeah, some of them are weekly, but again, most of them are either 2-week regimens or every 3-week regimens.
What is radiation doing to my cancer? So the idea behind radiation done after surgery is that it kind of clears out the rest of the area that's radiated. So if we do a lumpectomy and then you have radiation afterwards, the idea is that if there are any cells kind of within the breast that have the potential to become abnormal or cause a recurrence in the future, that the radiation helps get rid of those cells. I always tell people, and Dr. Yellala is a medical oncologist and I'm a surgeon, so we don't have a radiation oncologist on this panel right now. And I'm sure that our radiation oncologist is going to cringe when he hears me say this, but I always tell people surgery is kind of like eating the cookie and radiation is like cleaning up the crumbs, which is a terrible analogy. And everything in surgery is always food related, and I don't know why, because it's really gross. But I think that's a good way to look at it, is that surgery removes the tumor itself, and the radiation kind of cleans up any stuff that might be there. And radiation can be given to the breast, and if there's lymph node involvement, we sometimes give radiation to the lymph nodes as well. So the idea behind the radiation is we know that if it's indicated, that it really reduces the risk of recurrence very significantly. And so it's really a powerful tool that we have, and that's why, as Dr. Yellala said earlier, most people get multiple types of treatments because one is often enough to get rid of it, but not necessarily to prevent it from coming back. Is there a more common type of breast cancer that's diagnosed? Yeah, so I would say that among the subtypes of breast cancer, invasive ductal cancer, which is cancer that's arriving from the milk duct structures of the breast, is the most common subtype. And then for the hormone receptors?
Hormone receptor positive, HER2 negative disease is in general the most common biologic subtype of breast cancer. Triple negative cancers and HER2 positive cancers are slightly rarer compared to the hormone receptor positive subgroup. Yes.
And that means estrogen and progesterone, sensitive or positive, yeah. In what situation would a person get chemo after surgery?
So in general, again, the most aggressive kind of tumors which are high grade, triple negative or HER2 positive tumors require chemo before surgery, whereas most of hormone receptor positive, which is estrogen and progesterone receptor positive, HER2 negative tumors need chemo after surgery. Not most, I would say, when I said that, between the 3 biologic subtypes, the hormone receptor positive ones are the ones who get chemo more often than not after surgery. And in the past, we used to offer chemo for plenty of these patients. However, in the last decade, there have been so many updates in this space where we now look for a specific genomic score, either with an Oncotype DX or a mammoprint testing. And that is a genomic risk of your specific tumor. It analyzes your tumor DNA and RNA and comes back with a score level. Based on this test, there is a significant amount of women who can avoid chemo post-surgery in this particular subtype of breast cancer, which is estrogen and progesterone receptor positive, HER2 negative. Let's say if there is a HER2 positive tumor or a triple negative tumor, which is very small, less than 5 millimeters, which is, often only detected by screening mammograms, and people generally don't feel a lump in these situations. There can be a possibility of surgery, and then we can do chemo later, even though they're biologically aggressive types of cancer. And chemo is, again, we always take it into context of how healthy a person is. The textbook answer is not the right thing to do for everyone who walks in through the door in my clinic, right? So we really tend to look at the person and their health status in general before offering chemotherapy. Let's say if someone who is 60 or 70 years old have a lot of other comorbidities or other health problems, but they have a pretty big tumor which is lymph node positive and is biologically aggressive like triple negative. Again, the main goal is to get it out, a larger chunk of it during surgery. And we have to take this into context of what your entire life expectancy is. So doing chemo first, even in highly aggressive tumors, is not always the right thing. So it depends on a lot of factors, specifically individual factors.
I think over the past decades, probably, we've seen more and more tailoring of treatment to the individual, not necessarily just using the textbook approach for every person that walks through the door, as Dr. Yellala said. So I think a lot of this, it can be frustrating because a lot of the answers are, it depends. But a lot of it really depends on you, your overall health, your wishes, your desires, and of course, then what does the science show? What do the studies show? And what can we safely do? Because at the end of the day, we have to be able to treat the cancer safely for you, or we're really not doing any favors, right? And so I think that so much of this is more tailored to the individual now than it was, 10, 15, 20 years ago. And so, we can give you generalized things, but at the end of the day, it's really about you as an individual and what's going to work best for you and your life and your disease and all of the things in the big picture.
Okay, a couple long ones, so I have to ask them, but if you can repeat them back to me.
Yes.
Sure.
Okay. Is there a benefit to start a PARP inhibitor 1.5 years after starting an AI for BRCA2 positive grade 3, stage 1, second primary breast cancer?
So olaparib, or a PARP inhibitor, is not approved in stage, what is the stage of the disease again?
Okay.
Can I repeat that?
Stage 1.
Grade 3, okay. Okay, so PARP inhibitor. So what the question is asking is there a role to starting a PARP inhibitor like olaparib or talazoparib 1.5 year, which is 18 months after the original diagnosis, for a grade 3 stage 1 hormone receptor positive HER2 negative tumor, right?
Yeah.
Okay, sorry. Yeah, but again, it is not approved in stage 1 disease as an adjuvant therapy. It's used in high-risk stage 3 disease for someone with BRCA mutated tumors. So for stage 1 disease, there is no FDA approval for olaparib, yet it is not studied. So we do not use it.
How is skin affected if further surgery needs to be done after radiation? Difference in healing even years out?
So the question was, how is your skin affected if you want to have future surgery on breast tissue or skin that's been radiated, even way down the line, years out? And the answer is that radiation causes some damage to the tissue and some fibrosis of the tissue. So that's why if you have a lumpectomy and radiation, for example, your radiated breast often sits a little bit higher and a little bit tighter than your other side. And in general, if you have to have surgery down the line afterwards, we're always a little bit careful because you could have a higher risk of having problems with wound healing on that radiated side. The blood supply can be not as good or not as reliable to that tissue. And so in some circumstances, say you had a lumpectomy and radiation treatment, and then unfortunately a year, 5 years, 10 years, 20 years down the road, you have a recurrence in that same breast. The question is, what do you do? How do you operate safely in that breast? And historically, we've told people that in that scenario, you should have a mastectomy because we can't necessarily deliver radiation to the same tissue twice. More recently, there's more data that says that sometimes it's safe to deliver additional doses of radiation, again, on a case-by-case basis. And some people have very, very small tumors who don't necessarily need additional radiation, so maybe they could have a second lumpectomy. But on the whole, radiated tissue is more challenging to heal than non-radiated tissue. It doesn't mean that we can't do surgery, but it means that we have to be a little bit careful and we have to be realistic in our expectations about what we can and can't achieve.
What is the treatment after chemo for HR positive? For how long do you have to do the injection and tamoxifen?
Like hormone receptor positive?
Yeah, I think the injection, so the question is how long do we need to be on endocrine therapy, which is tamoxifen, after chemotherapy in someone with hormone receptor positive disease. And I think it's also a question that included an injection, which I think is ovarian suppression agent. We do not need to use an ovarian suppression agent like goserelin or Zoladex that you hear for everyone who is premenopausal. There are certain subset of high-risk patients who have either a larger size tumor greater than 4 centimeter, or in very young people, meaning less than 35 years of age, or if there is a lymph node positive tumor that we use ovarian suppression agent like Zoladex in addition to tamoxifen. But tamoxifen in general is recommended to be taken at least 5 years, in most instances 10 years in premenopausal women, because when you see premenopausal women, they're really less than 50 years of age and they have plenty of life expectancy ahead of them, right? They have 20-30 years of life expectancy. So hormone receptor positive, HER2 negative breast cancer, unlike the other subtypes, do have the tendency to recur after 5 years in some patients, and that is where the recommendation for 10 years comes into play. And they have clearly looked at it, and 10 years is better than 5 years. Where would I stop at 5 years? Again, it depends on the side effects that the people are experiencing while on this medication, because although I say it is an endocrine therapy, most people tolerate it well. There are definitely a subset of women who suffer from this, and I see it daily in my clinic. I know it happens. So we also really have to talk about what kind of side effects. Is there anything that we could give you to help with your side effects? Because our goal is not to make your life miserable on these treatments. We want you to have a reasonable quality of life, also getting the benefit from the drugs that we give you. So the answer is at least 5 years, but preferably after 10 years if you have no side effects and you can tolerate it fine.
Can you explain the oncotype?
Can you explain the oncotype? So oncotype is a genomic risk score. So it analyzes the tumor RNA and DNA, and it is a 25 genes that they look at, and they come up with a risk score ranging from 0 to 100. And this is a test based out of California, so it takes about 3 to 4 weeks after the surgery is done for it to come back. And you know, that is unsettling to some patients where they don't know if they're going to need chemotherapy for about a month after surgery, right? But I do not give chemotherapy before 4 to 5 weeks after surgery. You have to give the wound enough time to heal before I give you chemotherapy. So that really is not a something to lose peace of mind about. But the oncotype score, again, it comes back with score from 0 to 100. There are a few studies like Taylor-X, NSABP30, as well as R-Expander in lymph node positive women, which looked at what women with what scores benefit from chemotherapy. Rule of thumb generally is in someone who is postmenopausal, meaning they did not have their menstrual periods for over an year and their hormone levels are in the postmenopausal range. If a score is greater than 26, you would benefit from adjuvant chemotherapy. There are some studies which said that the higher your score is beyond 26, the more benefit that you will get from adjuvant chemotherapy, but it's not always true. And the recommendation right now is even if you have a score of 27 or 58, you would still require chemotherapy. That is in postmenopausal women, and if the score is less than 26 in them, I will not recommend adjuvant chemotherapy, because this set of population did not show any benefit from adjuvant chemotherapy. They do as good just receiving a hormone blocking pill for about 5 to 10 years after without chemotherapy. It's slightly different and complicated in premenopausal women who are less than 50 years of age. The blanket statement is if the score is less than 15 on the oncotype 1-5, no chemotherapy. If the score is greater than 26, yes, there is an absolute benefit from chemotherapy of greater than 15%, so we recommend it. The gray zone is between the scores of 16 to 25. Even in that 16 to 25, women who have a score of 16 to 20 have an absolute benefit of about 1.7% from chemotherapy. That means, let's say your risk of the cancer coming back at 10 years is about 8% with hormone blocking pill alone. If I give you chemotherapy, that risk comes down to 6%, which is, a 1.7% benefit. So some women say, I want to do anything and everything. Even if it's a 0.05% benefit, I would want to get the benefit. And some women say for a 2% benefit, I would not go through 5 months of chemotherapy. I'm not willing to take the side effects from chemotherapy. And both of these women are reasonable, right? Because it's your body, you're getting the chemotherapy, you're going to deal with the side effects of chemotherapy. So it's really a discussion if you fall in that gray zone of 16 to 25. We talked about the 16 to 20 where there is 1.7% benefit of chemotherapy, but the other subset is 21 to 25 where there is about a 6.7% benefit from adjuvant chemotherapy. So it's really a discussion. So, but that is what the Oncotype score means. It's basically a genomic risk score that predicts how high likely is this tumor to come back at 5 to 10 years down the lane. And that is what I base my chemotherapy decisions on in someone with hormone receptor positive disease.
Do you recommend clinical trials?
Absolutely. That's how the treatments that are existing in like today's day came from originally, right? If we didn't have clinical trials, if we didn't have research decades ago where multiple women participated, we would not all be getting the benefit from them today. Again, there are certain standard of care treatments, right? A clinical trial is always beneficial. The more options you have, the better it is in any kind of disease or scenario. But again, it becomes even more important when we don't have an answer to a particular question in a particular subtype. So we do offer clinical trials at Nebraska Medicine, and there are multiple trials available in multiple biology of diseases of breast cancer. And whenever a clinical trial is available to you, we do recommend it. We always present you with the options, but participation in clinical trials is voluntary, and even if you start on it, if you experience any side effects on it, there is always an option to withdraw from the clinical trial.
I think some people worry about clinical trials because they feel like maybe things are experimental or they don't want to be guinea pigs or all of those kind of things. Or if you've had maybe a bad experience with the medical system in the past, then it's hard to kind of put your trust in the standard, let alone this, trial that we're doing that we might not know the answer to these questions. But I think what's really important to know about clinical trials is that by the time they get to you as a patient, these have been through multiple stages of analysis and careful vetting and making sure that things are as safe as possible. And so, as Dr. Yellala said, they're always completely voluntary. You never have to go on a clinical trial. But I think that there was a lot of benefits to understanding different treatment options. You potentially could get better results from different treatments that would not be normally offered outside of the setting of the clinical trial. And if we're doing things in kind of a more experimental or off-label way, our recommendation is always that happens within the context of a clinical trial, because that's where the checks and balances are in place to make sure that you're safe. So trying to do a more experimental treatment outside a clinical trial without all those safety checks and balances in place to keep you safe is not a good idea. But in the clinical trial, those things are built in. So it's always an individual discussion and option, and not every person is eligible for every trial or anything like that, but certainly they're a very powerful tool that that drives forward our treatment options and may result in better treatment for you as well. When is it recommended to get a PET scan?
So PET scan is a staging scan. Nowadays, people are all about PET scans, but again, it's synonymous with a CT chest, abdomen, and pelvis, and a bone scan in breast cancer patients. Any patient who is stage 3 or above, we do recommend staging scans, whether it be in the form of a PET scan or a CT chest, abdomen, pelvis, and a bone scan. Stage 1 and 2 breast cancers are quite small and they rarely spread beyond the lymph node regions. So a PET scan or a staging scan is not recommended for stage 1 or stage 2 breast cancer patients.
Why did you both choose oncology? Oh, this is a nice question too. Oh. So I chose to become a breast surgical oncologist because when I was doing my general surgery residency training, I realized that I really loved working with our breast surgeons, and I loved working with that patient population. I realized that a lot of people do really well with their breast cancer diagnosis, and that's an incredibly rewarding kind of practice to be a part of. You get to have long-term relationships with your patients. And then when I was probably in my more senior years of surgical residency training, I realized that there was this thing called oncoplastic surgery, which means you take the cancer out and then you make it look pretty at the end of the day. And when I figured that out, I was like, all right, this is it. Like, this, what gets better than this? You get to take cancer out, you make people happy, you make it look good at the end of the day. Like, that was it. I was sold. So that was kind of my pathway to becoming an oncologist.
Great to know. I didn't know that. So it's very interesting. So I did most of my medical training in India before coming here to the US. So in India, you don't have the resources to diagnose cancer early. You don't have the resources to treat cancer appropriately, meaning a lot of these women come when they're very advanced, when they have fungative tumors in their breast, which is quite distressing to look at. So, or, feel as a woman having that, right, So when I came to the US in my initial training stages in medicine, oncology is always something that I was attracted to in the way that you kind of become a family physician to the patients, you develop a long-term relationship with them, which is meaningful. I will be with you in the most difficult phase of your life when you're going through a difficult diagnosis and treatment. Coming to breast oncology, again, when I was doing my fellowship training in oncology, I see a lot of young women who have plenty of questions in terms of how this is going to affect their future in general, So I love developing these long-term relationships with women, and breast cancer is a cancer which has a very high cure rate, meaning a lot of these women do have a difficult part with diagnosis and treatment, but they come out of it as a survivor and a thriver, and I love being part of it, and I still do to this day, and I'm sure for a long time I will. Yeah. Okay.
I just want to say thank you guys so much for joining the live, and thank you to Project Pink for having us. I think this is such an important topic, and it's been really fantastic to be a part of it.
I agree. Thank you so much for having us and for all your questions and your participation. Hope we answered your questions.